all. This is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. So today's discussion is about Molnupiravir. We have done one discussion about the mechanism of action of Molnupiravir in the past. So if you like, you can uh, search in my videos on YouTube Molnupiravir, and you would see the mechanism of action done in more detail. Today, what I wanted to do was to discuss the phase 2 and 3 trial results published by Merck and their partner. So let's discuss that basic summary. Let me give you the summary before. And the partner name for the Merck is Ridgeback. That is the company. So here is the basic summary in maybe, let's say, 30 seconds, and then we'll go in the details of it. The basic summary is Molnupiravir is an antiviral for COVID invented by Ridgeback, which was in association with Emory University. Emory University handed it over to Ridgeback. Ridgeback was then funded by, I believe, Wendy Holman and Wayne and Wendy Holman, and then with Merck to distribute it, just like Pfizer BioNTech. So BioNTech was the inventor, and then Pfizer became the distribution platform. The drug itself is a RDRP disruptor, and what it does is it's a fake raw material for the genetic parts of the virus. So it is a fake nucleoside, or it is a nucleoside analog. So imagine if you're building a house and the bricks are needed, and some of the bricks are not made up of the correct material, but they are made up of paper. And so when you install them in the walls start crumbling, or the machines that are going to install, those machines get stuck because those bricks are not correct. That is what Molnupiravir does. So it is an RDRP disruptor. We have other drugs as well that can be RDRP disruptors too. With this, the summary of the efficacy, it is a phase 2 and 3 trial, just like bamlanivimab. The trial has a smaller number of people, 733, and when you divide that further into groups of doses, there is a group for 200, another group for 400, another group for 800. Then there is another part of the trial where there is 800 and placebo. So there are multiple groups. So 733, you divide that into two basic parts, placebo and groups of drugs. And then you take the drug groups and further divide them, the 385 people, then that becomes a smaller and smaller part. But that is a phase 2, how to see the drug dose. And phase 3 is that it is also seen to see, does it have its effect? It is a placebo-controlled, randomized, double-blind test in which they actually stopped it before the full-blown 1,500 people's test, because the interim results showed good results. About 50% of the patients, or there was 0 deaths on the Molnupiravir side, and there was 50% efficacy compared to the placebo. So that is a lot of good benefit. And I had said this before as well. All politics aside, from a humanities point of view, there is one more drug that will be available. I have no financial or influence or strings attached with Merck or with uh, Ridgeback, and I am not a fan of Merck. But that doesn't mean that if we have a new tool, we should not look into it and understand what it is. They have said, again, still the summary, they have said that it is used for, and this is the first drug with this claim, prophylaxis. Or let me back up. First drug which is about to be authorized EU aid with this claim. There are drugs like ivermectin or hydroxy with these claims, but they were never approved. This drug is useful for prophylaxis, useful during the treatment, acute disease, and useful for reducing the transmission, or they even use the word prevention. So we'll look into that. This is the first remedy, first drug that is claiming that this may help with reduced transmission, and they are actually running a trial right now to figure that part out. So this will be the this will be a good drug uh, when it is fully authorized. So let's start looking into this. I'm going to share my references first. So this is drbeen.com. And then here, one more page I wanted to share with you. This is drbeen.com/interview schedule. So I have started putting the schedules for the people who are coming in for the interview. For example, we just recently had Dr. Priya J. Singhani, and you could click here to go and watch her lecture. Then tomorrow morning, 9:30 a.m. Pacific time, Dr. Daryl DeMello will be with us. So tomorrow we will not have a talk in the evening because we'll have a talk in the morning at 9:30 a.m. Then October 8 October, this Friday, this week's Friday, we'll have Dr. Bilkis Shabir. She is head of a internal medicine department in Mayo Hospital, Lahore, Pakistan. That is actually the hospital where I had done my house job, and it is associated with the university, King Edward Medical University, which where I studied. So I'm honored that we have someone from there. Then Dr. Priya J. Singhani will be with us. Dr. Shankara Chetty will be with us on 20th October. And next week, we will also have our own Cool Bean. He is a Six Sigma master, and he is Paul Bork. He will be with us to make sense of the Ireland's data a little more. So I'm just introducing this page to you to please keep an eye on this page. Continuing, this is the publication. So if you see here, October 1, and again, I'll continue to say financial aspects, political aspects, influential aspects aside, from a mechanism point of view, this is a good drug. And once again, there is no one standing behind me from Merck to ask me to say this. From a mechanism point of view, it is a good drug. So when there is a good drug, we should look into it. They copied some mechanism. This is not a copy of the ivermectin's or hydroxy's or zinc's mechanism. Ivermectin has, in theory, disruption of RDRP. This drug has the RDRP disruption as well. Their mechanism of disruptions are different, but they attack that simple thing. Ivermectin has other functions too. This is the clinical trial for Molnupiravir. And then this is another trial that is running for Molnupiravir COVID-19 reduction in transmission trial. So that is interesting. If you go back here to this trial, you would see, if I can increase the size here, look at the dosage: 200 milligram, 400 milligram, 800 milligram, then placebo. This is one part. Then there is another part, 800 milligram and placebo. This is the other trial. And finally, this is also very interesting that so the trial results are coming out now. These are interim results. They have stopped for the trial because they feel that efficacy is there. And unfortunately, there have been 8 deaths as well in the placebo group. I actually think nowadays doing these kind of trials is a tough decision to make because people are dying on the placebo side. So they did good to stop and say, let's go for the EUA and let's start having it used. Having said that, in the US, it has been already purchased in June. So I don't know what was the discussion back and forth, that the trial was not yet over. However, in June, US had paid $1.2 billion to buy 1.7 million doses. That makes it about 700 something per course. It's not per pill, but one course. I do not know what is in the course. If the course is as it is here in the clinical, that will mean 10 doses. So $750, 750, let's say, around, for 10 doses, that would mean $75 per pill. And they said that internationally they would actually improve the price according to countries' capability to pay. So with this, let's now go to this is the summary. So if somebody just wants to quit here because they wanted to hear the summary, this is the summary. Now I'm going to go over the details with my illustrations. So if you want to see more in details how this whole trial came together, then please hang around with us. So here we start. So the question that needs to be answered today, what are the results for the interim analysis for phase 2 and 3 trial of Molnupiravir by Merck? It is also called MK4482 or EIDD2801. So objective for the discussion today, we're going to go over the phase 2 and 3 result. We'll look into the detail of the results, side effects of the drug, and then we'll see how US is approaching it. And finally, mechanism of action, which I've kind of already spoken a tiny bit. Now here is the results. So 720 people, 762 people, they were actually planning to have 1,500 and more. The clinical trial sites shows about 1,800 and something, but at 762, they had enough data back which showed that there is efficacy. Plus, on the placebo side, there had been 8 deaths. So they did correct to say stop, and now let's go for the EUA. On the drug side, the intervention side or Molnupiravir side, there were 385 people. In the placebo, there were 377. And here is the important data point for the whole discussion today. Hospitalizations or death. On the placebo side, 53 people out of 377. Out of these 53, 8 died. So 14.1% people got affected, including 8 dying. On the intervention side, 385 people. Out of them, 28, that is 7.3, almost half, 7.3% were hospitalized. None of them died. So that is a huge deal. And the p-value, if you see, is 0.0012. So it is a significant data result. So I would love to have this drug. So look, you all know that I am a big fan of ivermectin, hydroxy, zinc, quercetin. And we also know that there is a lot of resistance. So if we end up with a drug that is available, that has this efficacy in front of us, and is available to be given, so somebody who cannot take a vaccine, somebody who cannot protect themselves well, or somebody who is going to get re-exposed again and again because of their work or whatever life conditions, then it is important to have some drugs. And I believe if this would get approved, then there will be more drugs that will get approved as well that would improve the efficacy even more. So I am always a fan of mechanisms and good mechanisms. So here, after the result summary, so once again, this is another cut point. If you just wanted to have the summary, once more, we are done. So now continuing with the detail. Companies. 2 companies. One is the Ridgeback Biotherapeutics, Miami, Florida-based company, funded the development of Molnupiravir all by themselves. So it started with Emory University, then with the Ridgeback Therapeutics, that is where it was invented. Then they started partnering with Merck to be able to distribute it. Now, all equity capital originated from Wayne and Wendy Holman. So this is not a Merck funded, although now it is Merck funded and Ridgeback funded together, but originally it started that way. In terms of the orders, look, they're saying that this is a drug that is good for prophylaxis, treatment, and prevention of transmission. This is the first drug that is claiming that in the transmission area, it will be useful. That means if somebody is COVID positive at home, then the whole family can be given this drug to prevent transmission to them. So that is an important thing as well, which is interesting. So US in June, this is the only one area which is interesting for me to say. The interim results are coming out in October. US had in June decided that, hey, we are going to go ahead and pay $1.2 billion or promise $1.2 billion for 1.7 million doses. Now Merck is additionally preparing for 10 million courses, not doses, and I use the word doses above, it's courses. Course is 10 tablets. Now they're preparing for 10 million courses by the end of 2021. And it is not only US, there are many countries that are ordering it. Now, characteristics of the study. It is a phase 2 and 3. Phase 2, drug dosage. 3 is the efficacy, and efficacy across multiple kind of groups. So they combined them both together. This is a similar thing like bamlanivimab. This is also a hint for folks who are doing other drugs trials, which keep getting thrown out or debunked or banned or just dismissed. Look here, small number of people, 733. Then you divide them over the drug groups, dose groups, then there are really 4 groups on the drug side, and 300 people divided by 4 is really small number. But still, it is a combination of phase 2 and 3 together. So that is how to approach it. When I see certain drugs and their trials and I see the dosage changes, and then somebody else comes in and says, you know what, this is not a valid study because the dose changed. So instead of saying that the dose changed, they should say, hey, this was a phase 2 and 3. We were trying to look for the dose. So that is what happened here. Randomized, which is good. Placebo controlled, which at this time, if I feel that there is a drug that is useful, and if I have to do a test, this is correct. Placebo controlled is a gold standard. But if I have this thinking that people might die, I might just do a non-placebo controlled, but compare it to a similar cohort in other hospitals which are getting traditional or conventional medicine. Anyways, for the, I feel sad that in this way there are people who died as well. But that is how testing is done, trialing is done. Double blind. You can understand my discomfort here, right? It almost seems incorrect. If we believe in this drug, then give it to everyone and then see in some other place where the uh, similar cohort is present and who are taking conventional medicine, then compare them. But anyways, I want to move on from this point. And my apologies, Luffy is here. He's going to keep talking today. Um, um, so 1550 intended sample size. They stopped at 775. So give me 1 second. I'm going to see if I can let Luffy out. Okay. Apologies for the interruption. Back here, they stopped it at 775, and then based on the compelling interim results, they stopped the trial further. So then next is the duration. This started it in October 19, 2020. They were supposed to finish it in November of 2021, although a year later, almost a year later, they have stopped. So a long trial. The drug groups were 200 milligram dose, 400 and 800 milligram, given every 12 hours for 5 days, a total of 10 doses. That was the regime. The eligibility criteria was PCR positive, mild to moderate. So people who are at risk, and they had at least one risk factor as well. Mild to moderate, PCR positive, symptoms within 5 days of the starting in the trial, and had at least one risk factor. Now, how did they do this? There were planned 170 sites worldwide, including these. So if you see here, there are Argentina, Brazil, Canada, Chile, Colombia, Egypt, France, Germany, Guatemala, Israel, Italy, Japan, Mexico, Philippines, Poland, Russia, South Africa, Spain, Sweden, Taiwan, Ukraine, UK, and US, out of some of them. So if there were 170, I don't think they went to all of them. But if there were those. So you can imagine a smaller number of people in every country and area would have been tested. And they also saw that the drug was equally efficient against various variants. And we can understand that RDRP, I have been talking about this RDRP enzyme structure for a long time in other drugs behavior. RDRP is not mutating that much. So if a drug is attacking the RDRP, then the spike protein can continue to change, but the drug is really disrupting the RDRP. So all variants are a fair game for this drug. Risk factors. So in this trial, again, 700 and some folks, they saw that for the severe disease, the risk factors, top risk factor was obesity, then age greater than 60 years, diabetes, and heart disease. These were the top risk factors. And then the side effects. They haven't listed the side effects. And if you look at the clinical trial site, the results are not posted there yet. Hopefully soon we would have the report somewhere. But what they say was very interesting. Check this out. So this is from their article. Molnupiravir had adverse effects 35% of the people, and placebo had 40%. So really lesser than the placebo. Drug-related adverse effect 12% on the molnupiravir and 11% on the placebo. What were they exactly is still not known. At least I do not know yet because I didn't read it there. Then discontinuation due to adverse effects. So number of people who said, you know what, this drug is making me sick, I don't want to take it anymore. 1.3% on the molnupiravir side and 3.4% on the placebo side. If you see here, placebo side almost seems worst in terms of side effects compared to molnupiravir. So this is the discussion for today. I hope it makes sense. I'm gonna this is it. We are once again, we are done. And if you like, I just wanna give you a quick walkthrough of some of the things here that I highlighted. So if you see here, Merck, these are the code names for this. This risk of hospitalization and death reduced approximately by 50%. So 7.3% of the patient who received this had this. So this is what you just saw. Recruitment of the study has stopped because of the positive results, and now they're going to go and apply for the EUA. And then this is the remaining data over here. Let's do this. I'm gonna stop here, and then I'll come back for a chit chat in a few seconds. Okay, cool. So I was just seeing if there is any comment here or question here. Cool. So let's do more talk in the chit chat. So please like, subscribe, and share. And if you would like to support this work, there are 3 links in this description. You can buy me a coffee, or you can use PayPal. Buy me a coffee does not need PayPal. So if you don't like PayPal, you can use buy me a coffee, or you can use PayPal, or you can be a patron. All are fine. And if you do not want to support it that way, then just like this video, and that is sufficient support as well. So with this, thank you very much, and I'll see you in 5 minutes.